The spirochetes are one of my favorite groups of bacteria because I did my PhD on one of these species. We're going to talk about 3 different genera that cause a really wide variety of infections. The first genus we'll talk about is Treponema. The spirochetes have this classic corkscrew-like shape and motility. They swim very rapidly, generally. The species that we're going to talk about in Treponema is Treponema pallidum. There is a species called Treponema denticola, which can be found in the mouth, denti, right? Treponema pallidum is the causative agent of syphilis. These spirochetes are tightly coiled and they have pointed ends, and often they are too thin to be seen with light microscopy or bright field microscopy. Often to see spirochetes, you've got to use dark field microscopy or fluorescence microscopy. This particular genus must be grown in cell culture. We have not yet figured out how to culture Treponema in a standard growth medium. And it's very slow growing. It has an approximate 30-hour doubling time. The bacterium is missing the TCA cycle, and it needs the host for most macromolecules, which makes it very difficult to grow in culture because we can't necessarily provide all of the nutrients it needs. They kind of border on microaerophilic versus and anaerobic. They have much lower oxygen requirements than regular aerobic bacteria. It has been difficult to ID the virulence factors in this species. Whole genome sequencing has revealed some hints. They do encode 5 hemolysins and a hyaluronidase. Hyaluronidase is an enzyme that helps bacteria to break down connective tissue. They have a real lack of surface exposed antigens, and that helps to promote immune evasion because the immune system doesn't really recognize it. They're capable of adhering to fibronectin, and because of really the lack of a lot of virulence factors, it's believed that a lot of the symptoms of disease are actually due to the host immune response. So the infection that we're going to talk about is syphilis. Syphilis is the 3rd most common reportable infection in the United States. So not all infections get reported to the CDC, the Centers for Disease Control and Prevention. Syphilis is one that does get reported. The top 3 infections reported to the CDC are all sexually transmitted infections. We've talked about one, gonorrhea. We're talking now about syphilis. We'll talk about the other in a little bit. So approximately 130,000 cases reported to the CDC in 2020. The incidence of infection increases during different periods of time. It really depends. I'm thinking probably 2020, 2021 are a little bit lower numbers than we would have expected because of COVID lockdowns and restrictions. And when the 2022, 23 data come in, the numbers might be a little bit higher because people are out and about more. Syphilis can increase the risk of HIV infection because it can cause lesions in either on the penis or inside the vagina, which can allow the virus to get in. It isn't terribly contagious, but that does depend on the stage of infection in the patient. So one of the interesting things about syphilis is, where did it come from? So examination of skeletal remains recovered in the Americas, Europe, Asia, and Africa may have resolved the debate. The disease we know as syphilis is likely to have evolved from yaws and more recently basal. So these are diseases caused by different subspecies of Treponema pallidum that actually affect like the skin and soft tissue and bone. They're not common in the US at all. They're actually found, as it shows here, in Africa. The earliest evidence of treponemal disease was in Africa and appeared to have spread to the Americas through an Asian route. At the time Columbus sailed to the Americas, syphilis was well established in the New World, including the Dominican Republic, where he landed. In contrast, there is no evidence of syphilis in pre-Columbian Europe, Africa, or Asia. Thus, it is likely Columbus's crew acquired this New World disease and introduced it to the Old World population on their return home. So again, the theory of how people came to the Americas is that populations came across the Bering Strait from what is now like Russia into what is now Alaska. It used to be connected by a land bridge. People came over, blah, blah, blah. During that time, there were treponemal infections like yaws and beagel, but none of them were syphilis. So in the North American populations, which eventually migrated to South America, the infection mutated and evolved and became syphilis. So North America and South America were then isolated from Asia and Europe. So there was no syphilis in those places. But then Columbus came and he brought smallpox to the New World and took home syphilis to the Old World. So they call it the Columbian exchange theory. In the US, we tend to see the incidence of syphilis along kind of similar lines that we see with other sexually transmitted infections. It tends to be higher incidence in areas like the Southeast, kind of rural areas. Fresno County is one of the highest incidents in California. Primary syphilis is characterized by skin lesions. So you can see one here on the penis. These are actually painless and they will occur 10 to 90 days after infection. It's where the bacteria were inoculated into the skin. There are going to be lots and lots of organisms within this lesion, and the lesion will heal in a couple of months. And so, one of the questions that sometimes people ask is, well, you got this lesion on your genitals, how does syphilis spread if you see that lesion on your genitals? Well, people sometimes are embarrassed. It's not painful. It eventually goes away, so they don't seek treatment. And the other issue to think about is this is on external genitalia. What about people who have internal anatomy? These lesions, if they form in the vagina, are not painless and not visible, so you wouldn't even know you had them. If left untreated, primary syphilis will develop into secondary syphilis, which has lesions all over the body. Not like this, but you'll have flu-like symptoms and a rash develop. So this is one of the infections that can cause a full body rash. So a patient shows up with this and you're like, well, what is it? Is it chicken pox? Is it measles? Is it Rocky Mountain spotted fever? Is it syphilis? And then you're like, okay, well, this patient has a full body rash. Now they're going to seek treatment. But the symptoms and the rash eventually go away, which can lead to the formation of tertiary syphilis. Now the bacterium have gotten into various organs and tissues. They form granulomatous lesions of the bone and skin. And remember, the lesions that the subspecies that causes syphilis, those bone lesions are different from the other bone lesions formed by the other bacteria. We can have neurosyphilis or cardiovascular syphilis. Neuro tends to be more common in AIDS patients, but it can happen for other patients as well, and you can see a lesion here in this cross-section of the brain. Another risk is if a child is born to a mother who has syphilis, that causes congenital syphilis, which can be a very serious disease and even lead to death of the fetus. If you want to make yourself really depressed, I highly recommend that you read up on the Tuskegee experiment. And this occurred in the first half of the 1900s in the South, where something like 400 African American men were diagnosed with syphilis and not told they had syphilis and not provided treatment. And they spread syphilis to their wives. The wives spread it to their children. Even with the advent of penicillin and the marketing of penicillin, these patients were still not told they had syphilis because doctors wanted to see what it was like when syphilis was left untreated and to just monitor the course of the infection in these poor people. So This is one of the most serious breaches of medical ethics that we've ever seen in the US. But those of you interested in medicine, again, I highly recommend reading up more on it because medical ethics are very, very important. And that case is a huge illustration as to why. For the diagnostics of syphilis, like I told you, with a lot of the spirochetes, they're very difficult to see under conventional microscopy. You can do dark field. What we have here is direct fluorescent antibody staining, so anti-treponemal antibodies that are tagged with a fluorescent label, so you can see all the spirochetes. Culture is not available, but there are a lot of serological tests. The trick with serology is there are a lot of false positives. The bacterium doesn't have a ton of antigens on the surface, so you can get a lot of cross-reactivity with other diseases and host proteins. Syphilis is super easily treatable with penicillin G for early stages of infection, 3 doses at weekly intervals for congenital and late stage. Doxycycline and azithromycin can be used as alternatives for patients who may have penicillin allergies. It is not effective, though, against neurosyphilis. So if a patient has neurosyphilis, you need to treat them with that penicillin G. So if they're allergic, you do what's called sensitization to help reduce the allergy symptoms for penicillin. There are no vaccines available. I want you to reflect on why. What did we just learn about the bacterium that indicates why we might not have a vaccine available? So the only real prevention is safe sexual practices. So this was a headline a few years ago in the New York Times: hunting a killer, sex, drugs, and the return of syphilis. Outbreaks of a deadly sexually transmitted disease confound health officials whose obstacles include drug shortages, uneducated doctors, and gangs. One of the things I don't like about this is that they call it a sexually transmitted disease. There's a lot of stigma. People have a lot of shame around, sexual behaviors and sexually transmitted infections. So those of you going into clinical practice, it's really, really important that you're able to work with your patients without judgment, regardless of how they got the infection. Encourage them to prevent the infection next time, and so that they'll continue to seek treatment and engage in safe sexual practices. This is from the Fresno Bee a few years ago. A state law that went into effect last year mandates medically accurate, unbiased sex education, including lessons on contraception, HIV, sexual consent, and more. Health advocates say that's especially important in the Central Valley, which is home to 6 of the 10 counties with the state's highest teen birth rates. Fresno County has the 2nd highest rate of syphilis in California and the 3rd highest rate of chlamydia. So those of you who intend to practice in the area, once you become doctors or any sort of health professional, those are things you have to think about and be cognizant of.